To start with, I would like to say, nearly everyone sooner or later will experience a kind of an eye health issue in their life. In fact, more than 1 billion people do not have access to eye care service globally. So if you believe everyone counts, then we need not to just think about our own eye health, but rather we must raise awareness of those around the world who do not have access to vision care. As an optometrist, the field of low vision is our territory. It is where we can have a massive impact in enhancing patients' performance in their life as well as in the society. Those colleagues of mine who have worked actually in low vision clinic, they really know what I mean by. Well, let us don't waste time and introduce the first speaker, Mr. Haris Grozanik. Haris is an optometrist who is practicing as a hospital-based optometrist in Sweden. He has completed his master's degree in pediatric optometry and orthoptic in Norway. And now his focus is on a master project, which is about hospital-based study regarding refractive development in children. His topic today is low vision in Sweden and Norway. Mr. Haris, very welcome. And can you just come to the screen? Oh, you're there.
Yes.
Hi.
Yeah. You see me? Yeah.
No,
sorry.
I'm sorry. I was just reading through this and I was not paying attention. I'm so sorry.
Yeah. Yeah. Thank you. Thank you for your invitation and your presentation.
And sorry, your bio was actually very large and people just can go to our website and read. I have to just compact it as much as possible because of shortage of time.
You said enough. So thank you. Thank you for that.
All right. We all are ears to hear you.
Yeah. Thank you. So greetings from Bergen, city on the west Norwegian coast, to all optometry lovers and vision care providers. Like I said, I'm grateful and flattered to get the opportunity to give a little talk on low vision, and many thanks to Ms. Raval and Dr. Mandala for the invitation. So, Sweden and Norway are part of Scandinavia. It's sub-region in Northern Europe. This is just general information. So Sweden is the biggest country in Scandinavia and have a population of 10.4 million people. Swedish as well is at 16th place of richest country in the worldwide in terms of GDP and have high standard of living. Main resource of economy is timber, hydropower and iron. 4.5 million Swedish residents are employed and 1/3 have education higher than high school. GDP per resident is approximately $50,000. And Norway is second largest country in Scandinavia and have a population of 5.3 million. Residents in Norway enjoy one of the highest GDP, which is second highest in Europe and sixth in the world. And it's around $60,000. Gas, oil, and fish industry is main resource of country economy. So this was just brief information about these two countries. Healthcare will point that every person in both countries get primary healthcare. Sweden has a universal public healthcare system that is considered one of the best in the world. The central government dictates healthcare policy. 97% of the cost to run system are paid by the taxes and contribution from the government. The remaining 3% is covered by patients themselves, who contribute with a small copay a doctor visit. In 2020, government spent on the health, medical and social care nearly 102 billion Swedish crowns. And this is one of the largest expenses on the government. Norwegian healthcare system is public and is financed by taxation. Healthcare policy is controlled centrally, but responsibility to provide healthcare is locally. Local authorities organize and finance primary healthcare service according to the local demand. All participants in a Norwegian healthcare system must cover all medical expenses up to $240 approximately before they receive exemption card. Then their treatment for the rest of the year is free. Norway is spending on the healthcare per head basis approximately $6,887, and it's for the highest in the world. United States is the highest and have approximately $10,600 per person. Definition of low vision in both countries is defined according to WHO definition as visual acuity 0.3 in decimal or 6/18 on the best eye with the best refractive correction. Characterization of visual impairment is also taken from WHO, but I won't go in details because you're probably going to hear from other colleagues. We can also say that low vision is a vision loss that can be corrected with the glasses, contacts, or surgery. These definitions are defined by laws in both countries, and every person who filled these criteria get right for low vision aid or help. Now comes some statistical data for low vision in Sweden and Norway. In Sweden, there is no formal register, but there are some estimate numbers and numbers from Central Statistic Office. In Sweden, it's approximately 400,000 people with visual impairment. When I say visual impairment, that means visual acuity from 0.3 in decimal or 6/18 to 0.7 or 6/9. From this number, there is 100,000 low vision patients, and they are registered with one of the county's vision centers. There is approximately also 10,000 legally blind persons. In 2002, there was approximately 2,750 visually handicapped children aged 0 to 19, according to the Register of Visually Handicapped Children in Lund. Most common reason for visual impairment is AMD, cataracts, diabetic retinopathy, glaucoma, retinitis pigmentosa. We'll also point one thing.
Sorry to interrupt you. The most common is AMD for children, you say?
I didn't say for children. In general, AMD. AMD in general, it's one of the most often cause of vision loss.
All right.
Yeah. But we'll also point that since 1970s, Swedish children undergo screening to detect and treat vision impairment, which has decreased the prevalence of amblyopia and should decrease the importance of amblyopia as a cause of monocular visual impairment in the future. So every single child in Sweden undergo this kind of screening, which is fantastic. In Norway, unfortunately, register of visual impairment and blindness was discontinued in 1995 due to inadequate reporting and poor data security. Since then, no registration of visual impairment has taken place in Norway. But anyway, there are some estimate numbers. Report from 2018 about eye health assumed that there was 320,000 people who lives with some degree of vision impairment. It is estimated that 50% of all have moderate to severe vision impairment. And there is 9,300 persons who are legally blind. Most common reason for visual impairment is, like in Sweden, cataracts, glaucoma, AMD, and diabetic retinopathy. Neuro-ophthalmological diseases are common in children, such as cerebral vision impairment or some other syndromes. We'll also point that in Norway, in the last couple of years, it's given importance to stroke patients and their visual rehabilitation. These persons sometimes have normal visual acuity, but reduced visual field, and they get help in sense of visual rehabilitation or end with some kind of prism systems as visual aid. Administration of low vision. In Sweden, it's often GP or optometrist who refer patient to hospital for detailed ophthalmological examination. To get low vision aid, first patient needs to be examined by ophthalmologist, so eye doctor, who gives diagnosis and who check what's the reason to visual impairment and how severe impairment is. Color vision, visual field, together with OCT scan of macula is almost always included in examination. Occasionally, contrast vision, night vision, or other tests can be done according to the disease. After examination, ophthalmologists refer patient to low vision clinic, Center for Blind and Visually Impaired in Sweden. In low vision clinic, optometrists together with vision therapists work on best individual solution. In these vision centers, there is even possible to try out low vision products, equipment, filters, etc. So to summarize, ophthalmologists give diagnosis and reason for visual impairment. Optometrists in the Center for Blind and Visually Impaired check refraction and choose aid, equipment which suit best for patient need and patient symptoms. Everything needs to be approved by Vision Center for Blind and Visually Impaired. Cost is usually covered by public health system, but patient can have own share. Administration in Norway is pretty similar, like in Sweden. So patient is often referred from GP, optometrist, or other healthcare professional like neurologist, oncologist, or pediatrician. As in Sweden, first examination should be done by ophthalmologist who is going to diagnose disease or reason for low vision or impairment. After given diagnosis, we'll either go to optical shop or to Norwegian Labor and Welfare Administration office to try best vision aid or equipment. In optical shop, patients get help with the glasses as filters, prisms, contact lenses. Even they can try handheld magnifier or telescopes. But Norwegian Labor and Welfare Administration is responsible for complex equipment. In optical shop, optometrist is going to check refraction and prescribe best solution for patient need according to diagnosis and symptoms. And then they send application to the office, where office approve or disapprove application. So to summarize, ophthalmologists give diagnosis, optometrists try refraction, check symptoms, and try out aid or equipment which is best for patient need. Norwegian office is working with more complex and more expensive products which they loan to patients, and that's it. Now we came to solutions for low vision patients. I wouldn't lie if I said that low vision patients in both countries enjoy one of the best solutions in Europe and worldwide. Some of solutions visual aid is, for example, CCTV or closed circuit TV, video magnifier, glasses with filters, glasses with telescopes, monocular or binocular, handheld magnifiers, special lamps with different type of lights, aid to train braille or blind letter, reading devices, audiobooks, software for reading and writing, stampers with patient signature, printers, mobile phones. Orcam is very promising high-tech device which transfer visual information to audio information to patient, can even recognize friends. It's very, very promising high-tech devices. And there's more, but yeah, this is most often aid in both Sweden and Norway. All vision aid needs to be approved by authorities in Sweden's Center for Blind and Visually Impaired Persons and in Norway by Norwegian Labor and Welfare Administration Office. So everything needs to be approved. If it's not approved, that means patient cannot get anything from this list. Glasses with filters and magnifications are owned by consumer, but stuff as TV, reading devices, or other complex and expensive devices are owned by vision centers, and they are loaned to consumer, and they have responsibility to take good care. Government is paying big part of cost, but patient can have own share. Even in Norway, we have something called Statped, which is national state agency that offers special education service to help visually impaired children and adults within educational sector. In Sweden, we have Sweden National Agency for Special Needs and Education, which offers in-service training to teachers and paraprofessionals in education of students with visual impairment. So, how does the future look like? So, Swedish and Norwegian healthcare performs very well in general. Life expectancy in the country is high, and general health among population is good. According to the best healthcare in the world, Norwegian is at 15th place and Sweden at place 28. As many other developed countries, in Sweden and Norway are living longer and longer. The average lifespan among Swedes is 84 to women and 81 for men, and in Norway pretty similar, 84 for women and 80 for men. This positive development places demands on the healthcare system and increases the need for elderly care. For our profession, this means we will see more and more patients with age-related degeneration, cataracts, glaucoma, and diabetic retinopathy. So now I came to conclusion. There is some risk that in the future we can experience bigger number of low vision patients, but at the same time, with new advanced technology, we could turn around these numbers. Low vision patients need best possible individual solution help to give them joy in life, work, and society. Every country should have a register of visually impaired and low vision patients for all age groups. It is essential both for healthcare professionals and for government to know what expenses they can count on. Administration of low vision should be smooth for all parties. That means both for patients, eye care professionals, and office workers. Some of new technologies are looking promising, such as gene-based therapy or gene editing, OCR devices, that's like program which text-to-speech capability to read and display phrases and texts from documents, books, menus, and newspaper. As well, VR or IR, so virtual reality devices are also something we are looking forward in the future. Retinal prosthetic systems for RP patients, patients with retinitis pigmentosa. It's state-of-art system, but unfortunately, the cost of these systems are pretty high. It's approximately $150,000 dollars for one piece, and it's only available in 15 centers in the US. So it's not available in Sweden and Norway, which means that this cannot be paid by the government. It can only be paid by patients themselves. There is even some clinics who are working with restoration of therapy, like in Fedorov in Berlin, who restores visual function to non-invasive electrical stimulation of retinal cells and optical nerve fibers, which help patients with optic neuropathy, RP, optic neuritis, traumatic optical nerve damage, optical nerve hypoplasia, low vision after tumor, etc. last but not least, our profession is developing very fast and we need to hold our step with it. There are tremendous changes in treatment, solutions, and management for low vision and visually impaired persons. So, yes, so that was pretty much everything I had. Please excuse, I didn't know that probably it would be best to have one PowerPoint, but
it was awesome because you was like more about talking, not about diagram and figure, and it was perfect. In fact, it was more friendly, you know, it was just only you and we were listening to you. It was really nice.
But like I said, if it's needed, I can put on a PowerPoint and I can share with you. So there's no problem. But this is how it looks in Sweden and Norway. So we absolutely have a lot of low vision patients, but they get very good help. They get almost latest of the technologies and everything works very well, and these two countries are prepared for visually handicapped persons. So yeah, so we are blessed or lucky to work here, and yeah.
Guys, if you have any question, you can leave a message on the chat box, or you can put comment on YouTube. And Harris, for now, we have a question from you. That is, Manish actually asked, what would your low vision management in case of early diagnosis RP, retinitis pigmentosa cases in children?
So unfortunately, I had quite a lot RP patients because I work at the north of the country, and I remember in 1 week I had like 3 patients with RP, and it was like, wow, is it possible? Sometimes some person doesn't get any in his career, but I had like in 1 week 3 persons, so it was like, oh, wow. So management for RP, quite often it's filter glasses, which
for adult as well, because he has asked for adult as well as children.
In both cases, we had both RP for children and RP for adults. In both cases, the first aid is filter glasses, which improve contrast and give like
stimulation and all.
Yes, exactly. Right. So filter glasses is the first help for RP patients.
Okay. And Kailash also asked people with amblyopia. I think in low vision, amblyopia is like, you know, as if you put a drop of ink in the ocean, right? So if you treat amblyopia also, still low vision is low vision. Am I correct, or you do something?
Yeah, but you know, amblyopia, it's like monocular. So if we have amblyopia, the other eye it's quite good. So so in low vision clinic, we don't work with amblyopia patients. Amblyopia patients are getting help through occlusions and through the best possible refraction in the optical shops or in the hospital.
Okay, I got you. Kailash, I hope you are an optometrist, so you must know, you know, low vision is a clinic where we have a patient which they have tried everything it's possibly available in the world. If it's amblyopia, am I right, Harris? Is amblyopia therapy, if surgery, whatever you can think of, they have done, and they are hopeless, nothing have helped them, so they are in your hand. So I think the amblyopia, they must have tried it before in amblyopic therapy clinic, and then vision hasn't improved to the certain amount. That's why they end up coming in low vision. And Harris, a question from me.
Yeah.
You said in Norway, patient actually should go to ophthalmologist first and get diagnosed and come to the hands of optometrists. So is there
Yes.
any way that optometrists have access to the low vision patient directly?
So the first examination of visually impaired persons should be done by ophthalmologist, and that's it. Ophthalmologist is done. Second time the patient is coming, it's coming right to the optometrist. So just the first examination should be done by ophthalmologist, where ophthalmologist is going to give diagnose that this person have RP, or this person have, for example, cataracts or AMD. So yes, the first examination it's by ophthalmologist. The second, the third one, it's by optometrist.
Suppose when you get a patient who is low vision, you are 100% sure, but for legal concern, you have to send him to ophthalmologist to get a letter to just declare that he has low vision, then come back to you as an optometrist, right?
Right. And this is the formal letter. That's like that's the formal document. So it's not just write down you have like AMD. No, it's the real document where ophthalmologists go through the whole history of a patient. So
I understand. Right. And another question is just running up. Okay. Nice presentation, sir. What will be the best option of low vision management in case of nystagmus in ARMD?
Yeah. So in nystagmus, quite often there's some studies that show that, for example, okay.
Guys, please just mute your microphone. Sorry for interrupt. Yes. You are mute. Harris, not audible. No.
Sorry. Okay.
Yeah.
So in nystagmus, if it's low vision, often it helps with as much plus as possible. If it's hyperopia included, but like magnification glasses in this case sometimes works. But nystagmus, it's pretty complex because when you have somebody with nystagmus, it's quite often neurologist who is involved in whole therapy. So yeah, in my clinic we didn't have a lot. And quite often the patients who have nystagmus, they have also some other issues, but we didn't have a lot, so that's that's good.
The practical aspects, nothing to say really. And he has asked, what is the management about diabetic retinopathy and central serous macular edema, or CSME?
Yeah, quite often it's injections. So that's like that's what they do in the hospitals. So that's what they do in the hospitals.
That's usual. Actually, that's the duty of retina clinic, you mean to say?
Yes, exactly. So that's a specialist in retinal diseases who is working with injections. After they are finished in retinal clinic, then they can come to optometrist, and optometrist it's going to, of course, to check best possible refraction, and to even prescribe some filters. So filters in this case as well, they work, and often they don't see very well at near, so we provide them magnification glasses. that's very often in these patients.
Harris, you know, the questions are just popping up for you, and we have other speakers waiting. So I will just save them to just ask you at the end. And, you know, some people are just sending me private message to ask you.
Okay.
So could you please just write your email address or Facebook or whatever, we can just approach you in case we are in shortage of time.
Yeah, of course.
Thank you so much for
I would love to answer all your questions. So what man? So here is my email address. So please be free to send any questions you have. So I would love to answer in a proper manner.
And I would love if you don't leave the meeting today and just wait at the end of presentation, I will ask you some question, all right?
Yeah, no problem. No problem.
Thank you so much, Harris. Thank you.
Thank you. And I hope some other time I'm going to prepare a little bit better presentation. No?
That was awesome. I really enjoyed. It was really perfect. And we have no idea what's happening in low vision in Norway. And you just light up our mind. Thank you so much.
You're very welcome. You're very welcome.
All right.
Thank you.
So bye for now.
Bye.
Okay, we have Miss Sonia Srivastava with us. She is the senior faculty with more than 25 years experience in optometry. It's really an honor to have her here with us. She's also in charge of Vision Enhancement Center in Low Vision Clinic and clinical training at Dr. Schwab Charity Eye Hospital. She has received Best Fellow Award from LVB Prasad Eye Institute in 1999, and she leads the Vision Enhancement Center with an objective of serving the visually impaired group and improving their quality of life. She is also collaborating with National Low Vision Project to establish and strengthen 21 low vision clinics in the eye hospital in different cities that doesn't really have the service across the country. Her topic today is low vision in children, which is a clinical approach. Sonia, madam, could we have you here with us?
Yeah. Hi.
Hello, welcome.
Hello. Thank
Pleasure
you. Thank you, Sonia. Thanks. Should I start I'll start sharing my screen.
Yes, please.
Is it visible?
Yes, ma'am.
Sonia, my skin is visible?
Yes, ma'am. It is very visible.
Yeah. Okay. So good afternoon and good evening to all my friends from different countries. And I was enjoying Harry's talk also. He has very well elaborated in his country how the low vision practice is. And it was a nice interacting with him, the way he's interacted and have spoken about the practices at their country. So my topic is a little different. Probably it's low vision in children, clinical approach. So I would be highlighting how you can approach a child when a child is having low vision into your clinic. Just to begin the presentation with some facts and figures. As we know that 253 million people are visually impaired globally, where 217 million people having moderate to severe visual impairment and 36 million people are blind. In cases of India, we have done a couple of studies earlier which shows that prevalence of blindness and visual impairment is 5.5% and 14.3% respectively. The childhood blindness globally, of course, it's a public health concern across the world. And as per the data, it has been shared that 1.42 million children suffering from blindness and 17 million around severe to moderate to severe visual impairment. Our Indian perspective is a little different, although India is the second most populous country in the world and carry 20% of the world's blind population, as the prevalence of blindness in children is relatively lower than the adults, but we also consider the largest number of blind children in the country. There is a significant portion of the population without access to basic health care. So like the children who are residing in rural areas and other areas are very different, because the approach and the access to basic healthcare services are not very well sound to the children or adults who are staying in a slums or rural populations. One of the studies in southern India shows that there are about 400 million children in India, uh, and the population-based study reflect that the prevalence of blindness in children in India is 0.75 per thousand population, whereas the blindness is 0.3 per thousand in well-developed states, and it basically varies, and it is more reduced in 1.5 by thousand, just because of the lack of sources and availability of the healthcare systems to these children. So around 15-20 years back, there was a study which has been done in southern India by Dr. Khan on the provision of low vision services and what are the barriers which we have dealt with earlier. So the major barrier was there was lack of training and knowledge in providing the low vision services and the personnel. There was a lack of awareness among eye care professionals that something can be done to make their life better for the visually impaired cater. Lack of motivations. There are many patients or children who were having a social stigma or cosmetic reasons not to adopt the devices. And in the same time, we were facing a lot of difficulty as there was a lack of good quality of low vision devices. The clinician felt there's a time consuming process and the lack of trained professionals were there in the eye care to provide these services. So that's how there was a poor integration and the communication between the referral systems and the low vision services and key service provider. But the trend has been changed, and current scenario of low vision services in India, there was a training institutes in low vision rehabilitation. The very short term and long term trainings are provided to optometrists, ophthalmologists, and eye care providers. The awareness among eye care professionals is increased and the referral practice has been increased. A lot of referrals are being coming by ophthalmologists to optometrists providing these services. Many of the community workers, national government organizations and international government organizations also been acknowledged these services and helping these patients out to receive the services through the eye care services. In fact, the awareness among the people having low vision also being improved by through social medias, websites, and of course the government organizations and the eye care professions too. So the systems of the referring patients have been quite improved with the help of overall eye care systems. Plus, of course, the major role is that national or government organizations and international government organizations to develop the system in the eye care services. So there are many NGOs who have come up and in collaboration with that, eye care services improved. And many of the tertiary hospitals have developed multi-facilities for the visually rehabilitations for the low vision patients. But there is still need to focus on community-based rehabilitation. As I've told, there are lack of services for the rural areas and the programs to integrate these patients into the society. So I think our main focus is now to make more rehabilitation professionals and of course to develop CVR programs. We are running Pelvin inclusive education where the children with visual impairment and normal vision are studying together. And this is being happening now as with the government policy, every school is being told or asked to have a special educator in the schools to help these children out. And the government have different policies and benefits also for these children and patients whom they can approach and they can avail these facilities too. This is a matrix which we are following in our country, and this is a visual matrix. And as per this matrix, we are categorized the visual disability in percentage. So as the yellow highlighted is representing the right eye better eye, and the brown one is representing the left eye better eye. So if someone has a 6/60 vision in the left eye and 3/60 vision in the right eye, would at least compromise of 50% of visual disability. That's a new visual matrix which has come recently 4-5 years back, which has been implemented across the system of our country. So although the children with low vision are basically born with diseases, like they're mainly hereditary diseases and congenital one, and most of them got the secondary diseases too. But the majority of the children which visits our clinic are albinism, aniridia, corneal dystrophy, cataract, high refractive errors, macular degenerations, glaucoma, microphthalmos, ROPs, retinitis pigmentosa, and optic atrophy. So these are the majority of the children which we see in our clinic. So what are the challenges which we face in pediatric group? Of course, there are more challenges we face compared to if you dealing an adult patient in the clinic with a child. The assessment part would not be any easier for the child. You have to have a child-friendly environment, interaction with the child, and child should be comfortable in having the assessment. The training of the use of low vision devices is very important because it takes time to understand how they have to device and how they have to use it compared to adult. So sometimes it requires frequent session to train them. Availability of resource materials, and because these children are going to schools, they have a different issues of school related issues, like sometimes they complain about doing board work, and sometimes the children have a photophobia, glare issue, would have a difficulty in mobility outside. So they might have an issue in playing games in outdoor activities, or sometimes they have a difficulty in doing a school works from the board at their own classroom. So there are different kind of difficulties they are facing when they comes to the clinic. And it's equally important to understand what is the educational media they are using. And the most important part, which I feel after a long practice, is that counseling of parents and understanding of the problem by parents is must. Because once the parents understand how the child is going suffer or what are the set of problems the child is facing, the job is become easier to teach parents how to tackle these situations at home or at school. So the aim of the low vision care is to educate patients and parents at how we can help them to understand the availability of options. It could be a glasses, it could be a low vision devices, it could be a high technology, advanced technology, assistive devices. It could be a resources through community, they can get it. And it's very important to counsel parents and teachers also to understand the functional implications of a child which is facing through the disease. It could be a visual acuity, it could be visual field, and it could be both. So starting with that assessment, the most important part is history. And of course, our informates are the parents or the primary caregivers who comes with the child to understand how is the child dealing with his vision, what are problems he is facing. We can have certain observation also while taking history, that how is the child is functioning, and what is that educational status, because sometimes we see the child in clinic, they have stopped education, and sometimes they feel that vision would go further down or further worse if they are using vision. That is also being seen few of the children who comes for the rural states or interiors part of the country. If we'll talk about the child with cortical visual impairment or cerebral palsy or multiple impairment, we need to have the history of seizures, or is there any drug intake child takes for longer time, or of the child having hearing impairment too, as we see in Usher syndrome along with retinitis pigmentosa, a person have a hearing impairment too. So we just need to take in this mind that child might require a multiple management plans along with that vision. Behavioral observations, it just looks the way child enters the clinic. Is he having any abnormal head posture or turning head, or is he have mobility issues, or is he squinting a lot, or is he very aggressive, or he's in the face of not accepting the environment easily, and the visual behavior, that is he making some eye contact, and what distance he is making, are they going very close and he is making eye contact. So all these things has to be taken in mind, especially the eye movement, whether the child has nystagmus or not. So in the history, of course, it is very important for a child that what is that status of his school? Is the child in a mainstream of school or with inclusive education or a special schools? Is studying is the medium of education is print or braille, and or if it is inclusive education or regular schools, the child is getting special educative facilities or no, how he is coping with the school environment, and second most important thing, his own classroom setup. So what are the levels of lighting and sensitivity to glare, where the child sits, is he really sitting in the front of the lane or back of the bench, and what is the position of and color of the blackboard or chalkboard? Is it a smart board or whiteboard? And how is the teacher is giving instruction? Is it verbal or is it always written on the board? So all these things need to elaborate with parents and child's both, so that we can work accordingly, that what are the areas and what are the tasks which is making difficult for a child to be in a classroom. So starting from the vision assessment, as it all depends what kind of age child is in. Is a free verbal child or verbal child? So accordingly, we can use the charts. It could be a picture chart. It could be Allen cards, Leah gratings, or HUTV. So depending on the child's age and response, we can choose the charts. And for children, neonatal infants children, where we are not able to do any kind of vision assessment, it would be difficult. Electrodiagnostic test like visual evoked potential is also preferred to understand the potential of the vision child is having. So later on, these childs could be gone for vision stimulation therapy or different kind of treatment by a vision rehabilitation person. Similarly, after the distance acuity measurement, we'll take a near vision. And near vision, I would just like to emphasize here, one is near acuity and other is reading acuity. So near acuity is just the vision chart we are using it. We should understand how is the child reading and what are the effects of illumination. So if the child is photophobic or having a glare issue, then probably we need to take this illumination account. But when we have to assess the visual skills, then the reading acuity comes. So it's equally important for a child. Reading and writing task has to be done in front of examiner and optometrist who is seeing the child, that how the child is writing, is it writing in a straight line, or whether the child is going very close, which generally happens. These children have a good accommodation and they generally try to achieve the magnification by relative distance magnification. So they go closer and they are using approach magnification to read the print. So this is also important while examining a child about his writing and reading skills together, because if the visual skills are poor, if the child is having difficulty in fixation, scanning and tracking, probably it would be difficult for him to read smoothly, and he might jump from lines to other lines, and those issues could come up. So it's equally important after the vision refraction. Of course, I will be talking refraction detail in my next slide. And ocular functions is important to understand the child is using both eyes together. So binocularity status to know, very important. Any specific squint he is having. So either he's using only one eye or both eyes together. And important part is the movements of the extraocular muscle is normal or affected. So it could affect his visual skills also, scanning and tracking, if the gaze is being affected by any of the muscles. Refractive error to treat most of the children having low vision and different kind of pathology are being carried out refractive errors too. And sometimes it has been seen because that automatic refractometer, it's not easily to test their refractive error. So always perform a retinoscopy and prefer to a cyclopathy refraction, because there are children having their accommodations also using. It is difficult to decide what kind of refractive error has to be prescribed. And a different kind of techniques, if the child is having very high refractive error, over refraction also can be preferred. And refraction is performed both objectively and subjectively, and we should give enough time while doing subjective refraction. The child should be able to give answers and felt comfortable before we finalize the prescription of glasses. Again, the functional vision is also important for the low vision children, because sometimes it happens that the visual acuity in the clinic is good, but still they are facing difficulty in doing their day-to-day task. So that's more important for them. So there are many various areas where we see all these children, like what are the size and font size, they can see it comfortably, the lighting requirements, the color perceptions. Many oftenly children with cone dystrophy have a difficulty in perceiving the colors, and optic atrophy patients generally have a poor contrast sensitivity too. So it's important to test the sensitivity, that areas where the child is having more troubles, and probably if you have a good assessment, then there will be a good management too. So when we highlight all those areas where the child is having trouble, simultaneously it can be corrected out. So most of the children having albinism, aniridia, cone dystrophy, having glare issues too. So of course, even in RP also, as Harris also has told in his talk, very important role of filters, because many times they're having difficulty in glare and contrast. It simply can be improved by the filters. So after all the assessment, it's very important that we have certain magnification calculations, and on the basis of that, we decide the level of magnification which a child is required. So what should be the ideal working distance? A child's comfortable or no? It's very important. And most important part is child should be comfortable to read his own material also. That's very important. So we should not always aim for a fine visual acuity for near. I think one should aim for an acuity which a child is preferring. So if I'm having a child of 6 or 8 years of age, would have a different kind of font size to read. But if I'm having a child of 13 and 14 years of age, probably he will be having a different kind of font size on the book today. So this is very important. And second important part again is lighting condition, because most of the problems or contrast related issues could be solved by the improving lighting conditions at home. So there are various kind of low vision devices, of course, which is being available, and of course we can categorize in opticals, non-opticals, electronics, and I'm just not going much in the details. Probably the Sarika would be taking more on the case-based approach. There are many devices for distance, like telescopes. It comes in a spectacle mounted form also, and handled form also. Then there are many devices for near also, like spectacle magnifier stand, magnifiers, hand magnifiers, with illumination, without illumination. There are certain devices which is very well accepted by the children, like bar magnifier and domes, because it's easily to use also, and it doesn't require a focusing. You can simply put the devices on the reading material and it will be highlighted and magnified. As we talk about opticals, there's a major role for non-optical devices too for these children, because many times simple having a reading stand and lamp makes their life easy. There could be a problem of child is using his own notebooks. A bold line notebooks can be preferred, letter writing guide to write in a straight line, or filters to enhance the contrast and reduce the glare are also preferred by the children. So these are a few tips of children using devices comfortably, and after, of course, giving a proper training to use the devices. There are some side scope glasses also, and instead of a telescope, because it's a monocular device, this is a binocular one, which is very, very accepted by the children. It comes in a clip-on also, it could come in spectacle mounted also, and it's very light in weight. It gives a good magnification for a child to do a distance work, and the reading caps are also being available. The child can do a 7 times reading work too. So very comfortably children are using the device. So there are portable video magnifiers, one of the electronic device, which is again preferred by many of the children. It has a zoom camera. You can enlarge the text, and you can change the color contrast also of the devices. It comes in a different forms, starting from 3.5 inch screen to goes to 12 on 10 inch display screen also. So depending on the need and the age of a child, the device can be given and child could be trained for use devices. Most of the time, these children having not having major issues for near as their accommodation is good, but still there are some diseases which is very progressive in nature. And once you feel the child's coming in moderate to advanced severe visual impairment category, probably these standards would help to read print whenever it's being needed. So I would just like to conclude accurate clinical assessment in pediatric population with low vision is a key to successful acceptance of low vision management and thus help them in education, social and recreational integration. So it's very important for child to have a proper regular follow-up because at one time you cannot dispense all the devices and the needs and requirements of a child keeps changing as he grows with the age. So it's important to them have a regular follow-up and interaction so that whenever they need any kind of specific devices or guidance, you're always there to help. And of course, it gives a good pleasure when you bring a smile on their faces and to help them to lead their life independently. Thank you.
Thank you so much, ma'am, for your nice presentation as usual.
अभी इसको stop कैसे करना है?
Ma'am, can you hear me?
Yeah, I can hear you.
Thank you so much for your presentation. And a few questions I just got through my private WhatsApp. That is how we can increase the awareness for low vision, like national wise, because and as you said, there are many people in India who doesn't have access to vision care. So how we can just raise awareness in those cases?
Yeah, it's a good question. Of course, when I shown you few studies that earlier the awareness was very low, and of course now the awareness is not that bad, but we just need to have a community-based rehabilitation program. We need to have a more social workers, and the most important part I feel that low vision services should be integrated in all the tertiary and secondary care services. So once it is being integrated in the eye hospitals and multiple centers of the secondary hospitals, so they know exactly what is being available. Second, I think we need to have more and more conferences and materials to display to ophthalmologists to make them understand that there is a need of low vision services and these patients also can get benefited through low vision devices. So I think in nowadays in all of the conferences and CMEs, we are having still a talks of low vision devices. We are displaying models and demos of the low vision devices there. So I think that's been improving through that we approaching, and I think we're getting awareness is being improved, and a lot of rural and referrals are being coming to the clinic.
Yeah, and I think in India, because media is such a powerful industry, if government can, fund for just paying for some advertisement or something national wise, so I'm sure even in slums, they definitely have TV, media is everything in India. So I think that's the shortest and the best way to just convey them. Look, if you have vision problem, don't worry, you're not blind. Still, there is hope.
Right.
So
I agree with you. The government has a different policies also for these blind and low vision patients. So they are having different schemes and they're having different policies also. So whether these are being aware of and they're getting use also of that. So I think that's a good step which government has taken. A lot of government hospitals have started setups of low vision clinic at their centers. So that's again because most of the people, they approach to government hospitals first. So they're having these systems at their centers. That's also helping to patients to get facilities over there.
Thank you. And Manish asked you, can you please explain how a cerebral palsy child lead to a vision impairment? Can you please clarify in details?
Repeat the question and just see.
Can you please explain how a cerebral palsy child lead to a vision impairment?
Yeah, cerebral visual impairment, of course, it's not only the visual impairment alone. It's an impairment, it comes a multiple impairment. So we are having a early intervention center and child development centers across the country, where these children have been taken care by occupational therapists, physiotherapists, and vision rehabilitation persons. So these children have been given vision stimulation therapy and different kind of eye-hand coordination exercises and stimulation exercises to develop the vision. So the parents needs to understand that vision is not at all a problem. It is a connectivity which is being having affected. So these children have been having a multiple therapist opinions and the management goes on. But of course, these children, when come to low vision clinic, if any of the devices we feel the child is being benefited apart from the glasses we are dispensing. But when you talk about early intervention, so these children are into the multiple vision stimulation therapy by a vision rehabilitation person.
Thank you. And Salal, I cannot read your question because I don't know what you mean by ND. Anyway, I just ask her.
Yeah, I can read the question. I think he is asking, in India, any organization available for providing low vision patients financial support to buy LBTs, right? So unfortunately, there is no proper organization who is supporting. But as I have given my presentation, many of the NGOs and INGOs are working for these patients to supply low vision devices. So we have been going to many of the INGOs like CBM and Sight Savers. They're helping a lot. They're providing funds to buy these glasses. Although the government have some scholarship schemes for the young individuals to purchase the devices, and it's going through that, but very less schemes are being there. Their schemes are there where you can have a scholarship program, and the young or child can take this scholarship and have his education and all the devices free of cost. But of course, it's not very well available in all the states, but definitely it's working for more of the more metro cities and the good states.
Yeah. And next question is, thank you for the presentation. Have you prescribed magnifiers to children younger than 7 years old? What were the benefits and challenges?
Yeah, we do that. We are providing that magnifiers to a child of 6 or 7 years of age. Generally, we don't prescribe a distance devices as the child is not very comfortable using the devices. So for those children, we guide the parents and teachers to make the child sit in the front bench, and maybe a peer group or maybe a schoolmate or batchmate can help the child in reading and writing. But generally, I have seen the children, they are going very close because of they are using approach magnifications. The reading stands and reading lamps are very beneficial for them to improve the contrast as well. And secondly, if the child is not reading on a straight line or having issues in that, the bold line notebooks can be given. So these are the bold line notebooks having a little broader space and darker lines, so child is able to see. Of course, not much of the distance devices works in the very young children, but of course, non-optical devices and approach magnification works for these children.
Okay. And someone is asking about diet. Does diet have any specific role in vision rehabilitation?
I'm not getting the question. Diet.
Yeah, diet.
In our country, even I have, for the date of today, I have seen many of the children who are coming from very poorest states. They're having vitamin A deficiency too, still. So probably I would not correlate the diet with low vision, but of course, if you have a child with vitamin A deficiency or going to progress this deficiency in the eye, probably the vitamin rich supplements diet and those things are necessary, but of course not with cases of low vision.
Thank you. And what things specifically should parents notice that their infant kids need to visit optometrists or ophthalmologists?
Say it nice. Say it again, Samaya, the question.
Like he's asking, if any family having a baby, what they should look for any abnormality in the eye, so they just go and visit optometrists.
Right, very nice question, because I think we all know the visual developmental stones, right? So whenever there's a delayed milestone, so it could be like the child is not fixating mother's face, or the child's eye is having nystagmus or shaking eyeball, or the child tends to close the eye, even if a simple light is having photophobia, or the child is not making any attractive toys. If you are showing it colorful toys to a child and is not appreciating at all, he might be appreciating the sound, probably he would not be appreciating the toys or colored objects alone. I think these are the emergencies and the alert. Probably a parent should visit an ophthalmologist.
Thank you. And ma'am, because we are getting plenty of questions from you and time is very
So
short.
I would write my email ID over here.
Thank you so much.
So probably I would love to have this query over.
Thank you. And thank you for joining us. Thank you.
Thank you, dear.
Bye. Bye. Okay. The next speaker is Miss Sarika Gopala Krishna. She is a senior optometrist in Shankar Netralaya Eye Hospital and also head of the Low Vision Care Clinic for past 12 years. She has initiated glaucoma support and awareness program, and he conducted awareness campaign in and around the state. She was honored as a fellow of American Academy of Optometry in 2014, and she's currently pursuing her PhD in the area of low vision. Sonia will talk about the case-based approach in low vision today. Miss Sonia, can we have you here on the screen?
Yeah, thank you.
Hi.
Hi. So thank you for the presentation opportunity, and I welcome you all. And it's a nice presentation, Harris and Sonia. So it was good listening to you. So shall I start my presentation?
Yes, please.
Can you see my slides?
And sorry, I just said your name, Sonia.
No issues. No
sorry,
problem.
I'm absolutely sorry.
I'm Sarika.
Sorry.
Yeah. So can you see my slides?
Yes.
Yeah. Shall I start?
Yeah, it's very clear, right?
Yeah. So hi everyone. So thank you for joining us today. So I will be presenting on a case-based approach in low vision for the next few minutes. So I got a very good introduction already. So I'm just moving on to the slides. Yeah, so today we will be understanding how you try to prescribe devices for patients with low vision. So that is a very important session for today. Just came out once again. Yeah. So as already Sonia had covered a bit of this. So just to tell the importance of low vision, the prevalence of low vision according to World Health Organization is 285 million people who are visually impaired worldwide, and 246 million people have low vision, and the rest 39 million are blind. In India, 64 million people have visual impairment, of which 56 million people have low vision and 8 million are blind. So the ocular pathologies causing low vision could be broadly classified into central field loss, peripheral field loss, and overall blur vision. So ocular pathologies like age-related macular degeneration, cone dystrophy would cause central field loss. Glaucoma, advanced diabetic retinopathy would cause peripheral field loss. Uveitis, retinal detachment, and other conditions would cause overall blur vision. So after all the best possible treatment, suppose the patient asks, doctor, will my vision improve further? And the doctor says, don't worry, please go to low vision care clinic. So we need to know what is low vision. A person with low vision is one who has impairment of visual functioning even after the best possible treatment under standard refractive correction and has a visual acuity of less than 6/18 to light perception, or a visual field of less than 10 degrees from the point of fixation, and who uses or is potentially able to use vision for the planning or execution of a task. So what I want to make sure is low vision is not equivalent to blind. So you can always improve the vision of patients with low vision. So these are the categories of low vision based on which the concession and benefits are given. So yes, the moment the patient understands that there is a problem for them and there is no treatment and the vision cannot be improved further, definitely they will be in the state of anxiety, shock, depression. There are so many stages they undergo depending on other factors. So finally, the low vision care, appropriate care, helps them to accept the condition and move forward in their life with confidence. So here is an example. A 25-year-old female had approached us who had an injury, acid injury, very worst injury. And what she had been left is only the right eye. And she undergone OOKP. So in that, she had a little bit of vision after the surgery, and her education qualification was just the school level, and her economic status was quite very less, and the primary need was to earn independently, and she want to live an independent life, because unfortunately she had very less support from the family members. So she wanted to achieve something in the life and wanted to be independent. So when we checked her vision using a Bailey-Lowy logmark chart, we understood that the vision in the right eye was 20 by 1200, which is 1 by 60, and near vision was N40, and that too partial, only the capital letters you could read, which is 5M at 20 centimeters. And the field of vision only central 10 degree was intact, and the refractive error was -3 diopters. So as a final prescription, what we gave her was with the -3 lenses, she could read 20 by 600. And for distance, we tried a CTV binocular telescope, which improved her vision to 20 by 400. And she was able to see the faces better. And for near work, +10 diopters with the 6 prism base in half eyes was given to improve the visual acuity to N20 partial. Since it's a very worse loss, just with a half-eyes magnifier, we will not be able to improve to N6. So this she preferred for seeing mobile and identifying currencies. But with the portable video magnifier, her vision improved to N6 for reading fine prints. So apart from that, we advised her head scanning technique. I saw many questions from the audience. What will you do for RP? For any peripheral field loss patient, we would first advise them a head scanning training, which will be helpful for mobility. And she was referred to a rehabilitation center for giving vocational training, and she was motivated to continue her studies. And also we gave a letter for availing disability certificate. She got pension, concessions, and job quota. So now, as every one of you was asking about what magnifier you will give for ARMD or diabetic retinopathy, take my word, you cannot tell just based on the diagnosis that this is the magnifier. So in my 12 years experience, I'm saying this. Every day we see more than 25 patients, and in a month we are seeing more than 400 to 500 patients with different ocular conditions. So it is not always that 2 RP patients are same, and not the 2 diabetic retinopathy patients are same. Their visual demand is going to be different. What is the magnification requirement? All these 4 factors are really important. So visual demand, magnification, ocular pathology. So if it is a central field loss, you have to increase the magnification. If it is a peripheral field loss, you have to decrease the magnification. So there are so many components, and the other factors include their economic status and their family support, all these. So we cannot conclude that this device is for this patient, but this session will enlighten you what are all the options available for patients with low vision, and even for those who have a severe visual impairment. So already Sonia had covered most of this. I just want to run through quickly few of the basic things that we have to give importance. So this is based on the history taking. So we need to ask a detailed history with open-ended questions, so that you make the patient talk lots instead of you talking, so that you will understand and develop a rapport with the patient, so that they come out with their real problems faced in their day-to-day activities. So it can be like recognizing faces or watching TV. For near, it can be reading, writing, or seeing the text. You have to be very, very you have to ask a in-depth question, so that you understand what exact difficulty the patient has, so that you will end up with the right management. So identifying the visual demand. So this is very important. So for computer, what exact difficulty? Many times they will say, I have difficulty in computer. So what difficulty you have while using the computer? That is the difference of asking an open-ended question. So they might say seeing a keyboard or the screen, and similarly in mobile, typing the message or attending a call. So what difficulty they face in their life matters a lot. And in case of mobility, whether they are restricted to home, and are they able to move around independently in familiar and unfamiliar environment, all that is important. And photosensitivity, whether they are happy with bright light and dim light and both, whether they do have any difficulty. So similarly for day-to-day activities, cooking, self-grooming, organizing things in a place, personal hygiene, currency identification, and color perception. So all these will be in our pro forma in a more standardized format, so that we ask all these questions to patient so that we don't miss anything. So just quickly to run through the assessment. So we use logmar charts, and that is very ideal for a low vision patient instead of using a Snellen. So for distance and near, we use a logmar chart. Actually speaking, theoretically, we should use full field tri-frame lenses. But sometimes if the patient is having a high refractive error more than plus 10 or 20, that time it will be a little difficult. So then you can use a regular lenses. So the contrast acuity and contrast sensitivity is different. I just want to make sure you understand the terms. So contrast acuity can be tested using Bailey-Lowy low contrast chart. And for color vision, D15 test can be done. And AMSLR is not only for metamorphopsia. You can understand the field of vision and the quality of vision many times. So the last decade had lots of devices. You would have already be familiar with all these. So you have a spectacle model telescope, handheld, monocular, binocular, autofocus, and for watching TV, you have a spectacle model binocular telescope, which will improve the visual acuity if it is better than 3/60. And these are optical devices for near, like spectacle, dome, cutaway stand, magnifier, pocket, and handled. This will improve the visual acuity of the patient if the presenting visual acuity is N36 or better. Similarly, non-optical devices, this will enhance the contrast and make them right again and identify currencies. So there are so many benefits with the help of non-optical devices. This can help as less as a patient with no PL. So this decade, so we have lots of electronic devices which are available at cheaper rates. So CCTV, which are portable ones, mouse model ones. Mouse model is the most cheapest model, and a scanner-based device, and Topaz, which are desktop CCTVs. So this will improve the vision even if it is as less as N64. So these are devices which will help for both distance and near. You can change the mode, and you can use it with different features. So it will help as less as 1/60 and N64. So suppose if these devices are not helping the patient to improve their visual acuity, you can go for auditory kind of devices. So the buddy player helps for patient with complete blind, and classmate reader help for patients with low vision. So they can download the e-books and the materials what they want to study, and they will hear the e-books using DAISY software. Then they will be able to do their studying task. So these are RNIB pen friend. This will record your voice in the magnetic label, and this can be stuck on any of the medicine labels or any other gadgets that you want. And later you can listen to it so that you understand and you are independent without asking anyone. So Intel Reader, again, it's a scanner-based device. It will read books, and it will scan and zoom for you. So in the next decade, I would like to concentrate more on the futuristic devices. So you would have heard of eSight, New Eyes, Orcam, iSyn. There are lots. So recently you have Google Cardboard, HoloLens, Samsung Gear, and Oculus Rift. So each one has different technologies, and there is a very big competition in the market that which one will be best for whom. So I would like to give you a summary of the study, what had been done in Shankaranathiralaya. So this is a Oculus Rift VR device. It's a virtual reality device. So with lots of struggle, we created a virtual bank scenario. We wanted to assess the functional parameters of patients with low vision in a more realistic way. So in a clinic, the patient will not be able to move their head or eyes as much as possible. So even though we encourage them mesenteric training, so in this scenario, they will be able to move their head, eyes, they are free to walk, go closer, far. And we assessed the visual performance in a virtual bank scenario. So these are some of the snapshots, and quickly I'll show you a video how it works, so that you understand better. Okay, I'll show the video at the end. So these are the assessment we done using a virtual reality platform. So distance contrast, near contrast, distant visual angle, near visual angle, and visual search, hit rate, error rate, preferred reading distance, spatial orientation, the time taken for performing the task. So these are the 10 scenarios we created using the virtual platform. And these are the tasks that the patient has to do in that environment, and visual parameters with different control levels. So this is another device, Ocular. This is a augmented reality device for intervening patients with low vision. This gives you a real direct view of the physical world, and patient will be able to see the image much enhanced than how you see in the real world. So patient with very less vision of as less as HMCF improves more than 6 by 60 and 6 by 38. So this is like a wow kind of device. So I just introducing this device to you. So I'll show you the video of that also at the end. So I just wanted to project how much is the visual acuity improvement. So this is presenting visual acuity. This is with refraction. This is with low vision devices, and this is with AR. So you know there is a significant difference in the visual acuity for distance and also for near. So same way, so you understand that there is a wide range of difference, and it improves both the distance, intermediate, and near visual acuity with one single device. So this patient with the visual acuity of 20 by 1200, with the AR device, it improved to 20 by 100. So this is a wonderful painting. We call it as Tanjore painting, one of the traditional painting that she could do on her own using the AR device. And obviously the quality of life gets improved. So there are lots of computer softwares. As you know, there are inbuilt modifications, magic, which will give screen magic.
Sorry to interrupt you, but it seems that your slide is not changing.
Okay.
I'm sorry.
Okay. Probably I'll try showing the video.
Because it's very interesting and we want to just see what you're trying to say.
Yeah, of course. So I'll just stop sharing and share it again. So I don't know since when it got stopped. So can you see now?
Yes.
Yeah. So I think probably, yeah. I was telling about the computer softwares. So you have lots of options like inbuilt modifications and magic software, which is a screen magnification software. And for complete blind patients, you have screen reader software. So you won't believe many patients with appropriate training, they work very fast. And when the first time when I saw this in a computer training center, a complete blind patient is using a PowerPoint animation much faster than what I could do. So I was very happy to see that. So kudos to all those trainers. So they have so much of patience. So similarly, you have mobile softwares nowadays. There are lots of apps in the Play Store. You have magnification gestures. You can tell any of your patient with low vision, even a presbyope or an older patient who has difficulty in seeing the fine prints, especially WhatsApp. So the talkback option in any mobile. Now, previously it was only there in iPhone. Nowadays, any smartphone will have talkback option, and it talks what the texts are. So apart from this, we teach eccentric brain training for patients with central field loss. We teach sighted guide technique, mobility training, and we do have a smart cane which vibrates and alerts you when there is an obstacle in front of you. So regarding daily living activities, starting from waking up from the bed and brushing, clothing, and currency identification, for all these, there are lots of gadgets available these days to make them completely independent for their day-to-day life. So we teach them home management training, cooking training, mobility training, and vocational options to earn on their own. So yeah, so this is a format of a concession certificate that the patient gets from the Indian government. So they get pension, scribe, reader allowance, loan for education and business, job reservation quota, income tax relaxation, and travel concessions, roadways, railways, airways. So one of the interesting questions which was raised by the audience is whether they will get devices at free of cost. So that's a wonderful question. Unfortunately, not in many states of India, but yes, in Tamil Nadu state and Kerala and few other states, we have made the government understand the real need, and they are giving a portable CCTV, which I showed in my initial slides. They are giving that at free of cost for school students and college students. So that is one of the initiative from the department, and we hope it will happen in the other states. So this is a multidisciplinary approach that we do in our clinic. Comprehensive low vision training, optical and non-optical devices training, assistive device training, independent living skills, counseling and referral services, early intervention and schooling guidance, braille training, digital resources training, computer training, mobile technology training, and employment assistance. We help in all these terms. And yeah, going back to the case which I discussed in the initial few slides, after 1 year, we were happy to see her doing candle making, and she earns approximately $26 per day. So that is quite a huge amount for a person to live in India. And the vision status was stable, and her economic status improved, and she wanted to do her PG course in correspondence, and she was preparing for government exams. And after 2 years, she luckily got a clerical post in a post office, and she is very happy with that, and she was planning to enroll in higher studies also. So we were happy that we guided her for the best. And yes, so appropriate low vision care can make a person happy, independent, and confident. So thank you.
Thank you so much for lovely and very up-to-date presentation. And if there is one sentence for me to just keep in my mind is now I'm tension-free, that this AI can never get position of optometrists in low vision, because as Sarika said, by diagnosis you cannot say this is the 8. No, you have to see the patient, you have to feel the patient. And sometimes when he comes to your clinic, I always say you are not optometrist, you are a psychologist as well. You could be a best friend for him to just convince him to just use these aids. Are a big job, guys, because sometimes those telescope and are awkward. So this is our job to just convince them to wear.
Yeah.
Thank you so much, Sonia. And can you please also write your email address, because we are just having less time for the next speaker, so people can just write to you the question.
Yeah. Do I have 2 minutes to show the video?
Yes,
Just 30 seconds.
Whatever you want. Yeah, of course.
Yeah, thank you. I just feel it's complete then.
Yeah.
So quickly, I'll run through the video. Yeah, can you see my video?
Not yet.
Now?
No, we just see the icon, the VR icon of the video.
So this is the challan in the bank. Can you see?
Not really.
Okay. I started sharing. Now?
I think it's going to start.
Okay.
Yes.
Yeah, so this is a 3-dimensional bank scenario which we created for understanding different visual parameters. So how they walk towards the counter, how they take a slip. So we did lots of understanding on what is the real-time difficulty of the patient, and then we designed this. So we just wanted to introduce to the audience so that they know something like this exists.
It was really a feat. Thank you so much. Hard job.
Yeah, thank you so much.
Can I just ask you one question, because he just keep asking me here also.
Sure.
Thank you, nice presentation. I'm happy that you emphasize the fact that you need to get detailed history from the patient, colleagues, and need to remember that low vision is goal oriented. So there's another question. Any question? Oh, they're just appreciating your presentation.
Okay.
And is it required all to write your full name or for their certification?
Yes.
Oh, that is for VSA or certification for low vision patient? I don't understand that.
Probably they're asking what is the certification.
Yeah, this is certification for
right.
VSA.
Yeah, so the name really matters a lot. So many times they are low vision patients. They
Okay,
cannot
I
say
got
they,
a question through my WhatsApp that what is the recent advanced equipment in low vision which you prescribe to your patient?
that's what I would say. It is a augmented reality device, so which will have a very enhanced image seen through that, both for distance and for near. It's a very markable improvement. So far in my experience, there is no such device existing which will give so much of improvement for distance and near visual acuity. And we did a qualitative study also. We gave them a home loan, and we made them use for performing different tasks in their home. So their quality of life score is improving very well. So they're very happy with the device. So only thing is, it looks like a head mounted display, so they have to wear it for a longer time. So in the future, we are planning to create a spectacle model AR device which will be really helpful for patients.
And is it affordable? Like the price
Yes,
is?
yes, it's very cheap. The headset cost 6,000 INR. And the mobile phone will be around 30,000. Nowadays, they have made that software. It's called Relumino software. It works in any smartphone. So you get smartphone as less as 10,000 rupees. So less than 20,000 rupees in Indian currencies.
Well done. Okay, thank you for your presentation. I wish to have you, more often at Vision Science Academy.
Yeah, thanks a lot.
Thank you. And please write your email address so people can just approach you for further questions.
Yeah.
Thank you. So our next speaker, Mr. Dider. He is an ophthalmic clinical officer with master with distinction in investigative ophthalmology and vision research. He is currently an assistant lecturer at the University of Rwanda. His topic today is low vision in Africa. That's the African scenario. Hello, Dider. Can we have you on the screen?
Hello, thank you for having me.
We can hear you,
I'll
yeah?
try to turn my camera on. Okay. Okay, I hope my camera is on as well.
Hello, very welcome.
Hello, thank you so much. I will try to be brief because I think most of the things have been said by the previous.
Yeah, you just focus what's happening in low vision in Africa, because we are really interested to know what you guys are doing, what equipment you are providing.
Okay, I will share my screen. Okay, I hope that you can see my screen.
Yes.
Okay, the topic for today is low vision, the African scenario. I'll try to give you the overview of what's happening in terms of managing low vision, but I will not go deep into clinical details. I will just, because Africa is huge, and different countries which has different approaches to managing people with low vision. So I'll try to give an overview of the common factors that are seen in all those countries, or most of them. A bit of general information is that, as I was saying, Africa is huge. It has 54 independent countries. The population is around 1.3 billion. But generally, Africa is divided into two. There is Sub-Saharan Africa, which would be the main focus of my talk, because the countries in the Sub-Saharan Africa have a similar social, economic, and demographic background. So I'll focus on that. Sub-Saharan Africa is populated by 1.4 billion people. The World Bank estimates that 40% of the population in Sub-Saharan Africa below poverty line, which make 30% of world poor people based on the National Poverty Index.
Sorry.
A bit of background, I think the definition of low vision has been said. I'll go into the global burden of visual impairment. There's a recent study that was published by the Global Burden of Disease study. It published recent estimates of the global burden of visual impairment. That's why I tried to summarize the interesting fact that was published. Currently, the estimation of world blind people is 43.3 million. And the prevalence of blindness for people aged over 50 years is 1.85%. In this study, they try to compare the previous data from 2015, and it's clear that the prevalence of blindness is decreasing, but the number of people who are blind is also increasing. This goes with the increase in global population. So far, but there is progress, as I was saying, that the prevalence of blindness has decreased by 28.5% from 1999 to 2020. This goes with the implementation of the Vision 2020, which basically aimed to decrease the burden of avoidable blindness, which leaves us with the unavoidable blindness. What do we do with the unavoidable blindness and visual impairment? It is projected that by 2050, the number of people who are blind will be around 61 million, and visual impairment will be 474, which basically is around double of what you have today. Okay, the burden of visual impairment in Africa. World Health Organization estimates that 20.4 million people have low vision in Africa. The prevalence, as in other places around the world, is higher in those aged over 50 years, and it's high in females than in males. And between 2010 to 2015, the prevalence of blindness decreased from 1.12 to 3.39. So basically, in Africa, the burden of blindness is decreasing, but there remains what to do with unavoidable loss of vision. Based on the regions in Africa, the West African part is the one with higher prevalence of blindness and moderate and severe visual impairment. So there are obvious trends that are obvious in African population. The African population is relatively young compared to other places around the world. This makes it that the crude prevalence of blindness is lower in Africa than in other places of the world. But the age standardized prevalence in Africa is high. This is worrisome because as the population will be aging, the age-related diseases will increase also, which will make the burden of vision impairment worsen. So there is a doom, if I may call it, ahead. So what is being done in Africa to prepare for that? First of all, I'll give you an overview of the structure of eye care in Africa. basically the patient, when they come to the clinic, they either come through the primary eye care or go straight to the private practice optometrists. So those who go through the primary eye care, which is basically the public institutions, they are referred to district hospitals where there are optometrists or ophthalmic clinic officers. Primary eye care is basically done by ophthalmic nurses. So then those who are at the district hospitals level or private practice, in private practice optometrists, those with low vision or who are suspected of having low vision are referred to provincial hospitals where the ophthalmologists are based. So at provincial hospitals, there are some surgeries that are conducted, like cataract surgeries, but more specialized surgeries are done at referral hospitals. So the people who goes to low vision centers come from either the provincial hospital referred by the ophthalmologist there, or referral hospital referred also by ophthalmologists there. So at low vision centers is where the low vision management starts, and they are also referred to school for the blind or center for visually impaired. So this is the patient pathway in Africa. The first stage is detection and identification. This is often done by in education system for the children or their parents, or they are detected first by healthcare workers, either complaining of their eye related problems, or coming for other diseases, and then they are referred to eye care. And then after being detected, they are referred through that chain that we described before. And then the final stage, which is where they are prescribed with low vision devices, is at the low vision centers, as I described before. So the services that are currently offered in low vision centers, obviously they start by examining the eye and then taking the history to make sure that they are apprehensive of the vision related needs. They assess the vision again, even though before the patient reaches to the low vision centers, their vision has been assessed, but also it is very important for them also to make sure that they assess the vision to know and to document the condition of the patient. Accurate reflection is done, and then they assess for magnification and they provide non-optical interventions as well. So obviously, people who practice in Africa, we are practicing in a low income setting. So the standards are lower to what you would expect in other countries, especially in the West. So the International Agents for Prevention of Blindness has published a guide of for setting up low vision centers. So the minimum tests and devices that are expected to be in low vision centers in Africa are summarized in this table. So there are vision assessment equipments, optical vision devices. Obviously, the ones that the previous speakers was saying that are quite advanced are not yet available in Africa. So we basically have the spectacle magnifiers, the foldable and handheld magnifiers, and the stand magnifiers and filters. But there is improvement. It's not a generalization for all countries in Africa, but this is the standard of what you would expect going in a low vision clinic in Africa. So the barriers to low vision care in Africa. The main barrier is the physical and the environment that our patients are living in. So, for instance, this is a low vision center in Tanzania, and it's the main reason that there's low uptake in low vision services is the environmental factors. People are unable to access where the low vision centers are located. Others do not even know, are not even aware that those centers are there. So there is the problem of infrastructure and accessibility. The second challenge is the financial factor. For instance, a study in Ghana surveyed among the low vision therapists and technicians, and 91% of them say that they do not have, they feel that they do not have enough equipment, low vision devices to conduct or to help their patients. So it's really worrisome if 91% feel that they don't have enough equipment and they are supposed to be taking care of patients. So this is the situation that we have here in Africa, and it's one of the main challenges that people with low vision are not being cared for as they should. Another challenge, this was for the financial limitation in terms of for the centers or for the care providers, but the patients also are unable to afford the devices that they were prescribed. So there is a push to include eye care services in universal health coverage to help or to facilitate the patients to afford the eye care services. But this is a long process and it has not yet been done. So it's still a challenge because most of our patients are poor and then they cannot afford most of the devices that we prescribe. So often there are some non-government organizations, NGOs that help for those patients to be able to access those devices. But if not, most of the patients are unable to afford them. Also, another challenge is that there is unequal distribution of low vision services. So most of the services are located in urban areas, and majority of our patients are located in remote areas, in very rural areas. So, as I said before, most of our patients live in rural areas where there is poor infrastructure, where the transportation is a challenge for them, given their condition. So that becomes a barrier for them to access low vision centers and low vision care. Another challenge is lack of training facilities and well-trained care providers. This is a main challenge because the workforce in low vision is really low, and in some countries where there is training of optometrists, they have the workforce that they need. But in most of the countries, there is no training of optometrists. For instance, in my own country, in Rwanda, we don't have optometrists. So we train middle-level eye care workers, or who are called ophthalmic clinical officers, who basically assist the ophthalmologist in providing the care, but they don't have the necessary skills to be able to help the patient with low vision. So another barrier that is a challenge in Africa is the implementation of policies. For instance, most of Sub-Saharan African countries have ratified the UN Convention on Disability, which basically say that assistive devices for disabled people should be equitably available and accessible for all people, irrespective of gender, age, or a type of impairment that they have. But this in Africa is not the case because assistive devices are not very affordable and accessible as well. Because there's a study that was done in Nigeria, and 50% of the low vision centers, they did not have low vision devices. So basically, patients go there and then they are prescribed low vision devices, but they don't have anywhere to get them because at the centers, which is where they're supposed to get those devices, they are not available. So another challenge is the societal awareness and information gap. So in our communities, there is a misconception which is based on sometimes cultural or religious beliefs. I put an example there in Malawi. Goma conducted a study and found that children with disability were considered to be a family curse. So they were not made to attend any clinic or care that they needed because the family considered them that they were cursed. So this is a problem that obviously need to be addressed with the increase of outreach activities to increase the awareness, but currently it is a main challenge because sometimes the services may be there or the infrastructures may be there, but patients are not do not access them because of this misconception based on cultural or religious beliefs. Some also consider the low vision devices to be not socially accessible or socially acceptable because of most of them they are used to just normal spectacle glasses that are prescribed. And then when they're prescribed, let's say magnifiers, they feel they're shamed in society because of they consider the low vision devices to be different. These are the main challenges that have been identified as the main challenges in low vision care in Africa, and there is a push to improve the eye care in general, but it's a long process, and hopefully with time things will get better. So thank you so much. This is the conclusion: is that the political will is the main influence that we change this course and make things better for our patients. Thank you so much.
Thank you so much, Dider, for your presentation. And this tragedy, which, you know, people who are having just low vision considered to be bad and curse, is not only in Africa, it's all over the world. Even in developed country also, there are societies that, you know, they are very close-minded. And I think it's not only our duty, it's actually like more international community should taking care of that. Like, why don't you guys in Africa ask help from organization like WHO or like UN to just fund the aids for this patient? Have you ever tried?
Yes, the funds are there, and as I said, the countries are different. So Africa is basically made by 54 countries. In some countries, they do have really good eye care services, but in some other countries, it's bad. Sometimes because of their political administration who do not invest in eye care sector. And in some other countries, it's basically systematical, and it's something that we take time to get better. But there have been progress that has been made, as I said. looking at the figures from 1990 to 2020, the progress has been made, but it's a journey, and I hope we get there with time.
Yeah, and I think, you know, those colleagues who are dealing with low vision patient at clinic already struggling as compared to other clinic, but you guys in Africa are actually suffering a lot, because, you know, sometimes I think you do so much hard work and give something to the child, and parents feel awkward if they use it, so all your effort go waste. I can imagine how many problems you would
Yes.
have.
Yes, that's exactly what we deal with.
Yeah. So guys, dear audience, if you have any question from any of our guest speakers today, you can write it down. They are available. They can ask you, or okay. He has asked, what can be done to combat challenges of low vision service in Africa, especially at your city, Rwanda?
I think, sorry, I think in my country, the political will is there. And the first step is to train the eye care workers and the eye care professionals. And this is actually where I'm working. So we're trying to train well-skilled eye care professionals. And this, we hope that will help to turn the table and enhance our system to be able to provide care for our patients, not only those with low vision and others, because obviously the cataract is still the main leading cause of blindness, and it's an avoidable condition. It's an avoidable condition that if we have enough workforce, we'll be able to change. And so that's the direction that has been taken, is to first train, and also various initiatives have been taken to raise awareness in the communities, to make sure that at least those who have the problem know where to go to seek care. So I think in my country, we are on the right path, and I'm quite happy with the trajectory that we are on.
Thank you. And Didar, you are getting lots of compliment. People love that your presentation, because you know, I can understand we have no idea what's actually happening in Africa, because of course there are lots of online access, but when optometrists here telling us the facts, it's really worth it. You know, thank you so much for your presentation. I really appreciate that. And guys, if you don't have any more questions, we can just say bye and finish the session. Yeah, they'll just keep thanking you. Thank you, sir. Thank you, Didar. It was nice. I hope to have you again more and more at VSA.
Yes, I'll be happy to contribute.
Okay. Thank you so much to our lovely speakers and to all of you who participate in today's Symposium. And I look forward to see you in the next sessions. Thank you so much. Thank you so much for your lovely comments to me and the speakers. And I would love to thank Dr. Abhishek Mandal, who actually put all the efforts. You know, you just see me, but on the backstage, he is the one who is doing all the effort to, you know, provide this symposium for you guys. Okay, have a nice day, nice evening, wherever you are. Yeah, okay. Bye, everybody.
Thank you.
Bye.
Thank you, sir. Bye.
Bye.